Okay, first we'll discuss stent ISR, mainly a result of a lot of factors, and we have to consider each and every one if we want to successfully treat it. So, intra-stent factors mainly uh, new intimal hyperplasia within 1 year and new atherosclerosis after 1 year, anything which prevents the stent from expanding. Under-deployed stent, under-expanded stent, lot of calcium, lot of previously deployed stent, all of these make this, the expansion of the new stent difficult and lead to, okay, what do you do when you get ISR? Busy slide, but just remember that you cannot rely just on your angiogram for assessing ISR. You have to use IVUS or OCT, whatever is available to you. Treat the underlying cost first before you go for the ultimate therapy, which is DCB or another DES. So get the IVUS done and treat the underlying cause. Okay, just we'll go through the cases. This is a 70-year-old lady presented with non-STEMI. The first is just a frozen image showing severe stenosis, proximal LAD, and not very severely calcified. So a 3.3038 stent, post-dilated at high pressures with 3.5, angiographically not a bad result actually. So she comes back after 7 months and with recurrent chest pain, and now we have severe ISR in the middle portion. IVUS was done and it was seen that the whole of the stent was very well opposed and open except at this localized area, and the cause of this was a very arc of calcium about 180 degrees behind the stent. So you have to get this stent open, but the problem is you have big calcium outside the stent. No matter how much you expand it, it's going to expand asymmetrically. So the basic idea is to get a good enough area rather than a good rounded appearing stent. So that's what we did, 3.5, high pressure up to 30, repeated inflations, and sometimes what helps is you go up and down on your balloon. Maximum up to 30, go down, do this repeatedly until you get a good area. Repeated the IVUS, the area was around 7 millimeters, so we were satisfied. What we did was deploy a DCB 3.5, and the result was okay, and she has been doing fine. Okay, another case, 70-year-old male, COPD, non-STEMI, severe ostial to proximal LAD, severe circumflex disease, treated with stent to the circumflex, good stents, stent in the LAD as well as from the left main to LAD. So angiographically, not a bad result actually. So again, left main post-dilated with 4.5, LAD with 3.5. So what happens? 11 months later, presents with this. Recurrent chest pain, posterior STEMI, brought to the cath lab. And so what is the cause of the ISR? Any fellows? Quick answer. Underexpanded, great. So this is ostial LAD, 4O vessel, clearly under deployed stent. Sorry. So what we did was took a 7 French guide, pre-dilated the ostium of the circumflex, 3.5 high pressure, 3.5 to the LAD, and then 4O. 4O non-compliant both to the left main LAD as well as to the circumflex. And then what we did was 4.4016 DES in the ostium of the circumflex, tap with a DCB in the left main to LAD, and in the end, not a bad result. He has been doing fine. Okay, another case, successful PCI to left main, LAD and circumflex, DK crush 5 months back. Now presents with cardiogenic shock, recurrent chest pain. So this is the anatomy. Again, as we were discussing the shock, the rule is when you are in shock, first put an IABP in. So IABP in first, IVUS was done, both the stents were not well opposed, not well expanded at the ostium. So they were high pressure inflations were done, and then 3.5 up to 30, simultaneous kissing inflation with a 3.520, and the result was not bad. Okay. So moving from the stent restenosis to stent thrombosis, we know the numbers: acute, subacute, late, and very late after 1 year, roughly 1% incidence, more so in the STEMI while we are doing primaries. High mortality, actually, you should remember that, 20% mortality and high risk of occurring again. And lot of factors are related. Again, the more complex the procedure, long lesions, diffusely diseased vessels, geographicness, slow flow, especially in the STEMI setting, long lesion, stent malpositions, and calcifications. Patient-related factors, all of these factors are important. Mainly diabetic, ACS setting, left ventricular dysfunction, renal failure, advanced stage, and high platelet reactivity, and issues with the antiplatelet agents actually. Okay. So another case. Oh, just a few words on late stenosis, late stent thrombosis, and very late stent thrombosis. A lot of these factors can contribute actually to this. Main is new atherosclerosis, which occurs after 1 year, and more so in the DS as compared to BMS. They can present, in fact, as a STEMIs because they have plaque ruptures, and they can present as de novo plaque ruptures. Stent malposition can be acquired because of late remodeling in the vessel, hypersensitivity reaction either to the drug that is being used or the polymer. All of these can lead to stent thrombosis, which can be late or very late. This was more so of a problem with the first generation stents actually. Now a lot of changes have been made, and this is now less common as compared to previously, but still occurs. Okay, so successful PCI to OM1, non-STEMI, looks good. Okay, 3 days later, STEMI, from non-STEMI to STEMI. So what we do is usually wire it, aspirate it, give IV agrostat, and gentle PUVA with a 2O balloon brought her back after 24 hours. Cause of stent thrombosis. क्या ख्याल है? Notice anything at the distal edge of the stent. So there is a dissection there, okay, which was not very apparent in the last angiogram. So this was tackled with another stent, and the result was good, and she has been doing fine. So stent thrombosis is usually not patient's problem. You think that patient दवाई नहीं खा रहा था. सबसे पहले सवाल हम यही करते हैं, दवाई खा रहे थे या नहीं? Usually खा रहे होते हैं. So stent thrombosis, if it occurs within 30 days, it is problem with the mechanical issues. Stent implantation, technical and procedural factors are important. Suboptimal procedure results, slow flow, especially STEMI, inadequate post-procedural luminal dimension, residual dissection as we saw in the last case, tissue prolapse is all associated with incidence of early stent thrombosis. In conclusion, stent failure is a real and challenging problem which needs precision therapy and management and can be largely addressed by meticulous pre, peri, and post-procedure management. Thank you very much for your patience.